Are you experiencing back pain that you can't get rid of? Getting migraines, vertigo, having trouble sleeping, and/or brain fog? Do you feel like your medical doctor doesn't understand your condition? Blair Chiropractic might be the solution you've been looking for. If you've ever been skeptical about this, the two doctors you're about to listen to were even more skeptical than you were when they looked into chiropractic work. But fear not. Get expert guidance from the blonde and the bald, Doctors Beth Bagley and Frederick Scherger. These two doctors have extensive experience beyond the healthcare realm and bringing unique vision and healing to their patients. What do you have when you get a biological analyst and an engineer together? Find out right here on another episode of The Blonde and the Bald. Welcome your hosts, Doctors Bagley and Scherger.
Welcome, folks. For those of you who are listening to this in your car as you drive around, because you're being as efficient with your time as possible, you will not see our lovely Sunday outfits.
No. But if you are watching on YouTube, you get to see these wonderful outfits because we're both probably dirty.
No, actually, I just took a shower.
Well, then I'm dirty because I just drove 5 hours in the car. So
where'd you go? You had called and said, can't do
our normal Thursday podcast. Yeah.
Yeah. So what's going on? Where did this trip take you?
So around Christmas time, I was trying to decide what to do, how to give teenagers a present, right? Because they don't want anything. They just want money to buy stupid stuff, and they don't play with toys anymore. They play video games. But so by the way, the answer is they're not musicians. And as I pan over here, there's the expensive toys that they could be asking for. So yeah, they could be. I would make them buy them with their own money if they wanted those. But so I was trying to contemplate, what do we do with these teenagers? Because there's 3 teenagers on my husband's side, the cousins, and my two 14-year-olds. So I thought, let's do like a weekend trip. And so we decided on Branson because I actually haven't been to Branson since I was like 9 years old. Goodness. So I was like,
you've been there twice now, more than I have, because I've yet to get there.
There you go. I mean, and I know it's a tourist trap, but I love that kind of stuff. I can honestly say that stuff is my jam. And we decided to go in the off season because it's February right now, and happened to be not snowing, but 60-degree weather. So we lucked out.
Definitely.
But off season travel is a lot less expensive because we were able to get our Airbnb for about half the price, and we're in like this $1 million home, which was amazing. Yeah. So all of that stuff was great, except on the way, honestly, even the Thursday before, as I was working on Thursday, I just didn't feel 100%. I saw a ton of patients because my associate was sick. Oh. And so I was seeing all the patients in my office myself, and I left a little late because we got jammed up and I got sick at work. So I didn't have anyone to check me at the end of the day. And I, got in the car right away when I got home, and we drove for 5 hours. And by the end of that, I was achy, sore. I just didn't feel real good. So when I went to bed after we got there, I started having these symptoms that I've had after a whiplash injury that I had 3-4 years ago now, where my body jerks itself awake over and over and over and over through the night. And it's not like just everyone's had that when you're about to fall asleep, you do that jerk.
Right.
But this is unstoppable. I mean, it's not like a seizure where it's like happening really fast. It's like I would start to fall asleep and then jerk, and then another 5 minutes and then jerk. And it happens through the whole night. And it is it's like abusive because you really think, okay, this is the time I'm actually going to get to sleep. I'm going to do it this time. And then again, I'm awake enough that I remember, I'm conscious. So I knew at that point that I was not going to have a very good trip because I didn't feel good. And so when we all woke up in the morning, we decided to go to the grocery store. And I had this thought. I was like, okay, it's Friday. And chiropractors are many times open on Fridays.
At least for the morning.
For the morning, yeah. And there's this young chiropractor that I've referred a few patients to in Branson. And his name's Dr. Jacob Llewellyn. And Llewellyn, it's an A. And I thought, this morning. I was like, I was calm. He answered the phone right away. I said, hey, it's Dr. Beth Bagley from St. Louis, Missouri. He's like, hey, how you doing? And he wanted to know if I needed to talk about a patient. And I was like, actually, it's more about me. And I was like, is there any way that you can squeeze me in this morning? And he looked at his books, and he's like a one-man show. So he's running the whole office himself, and he was able to squeeze me in. I was able to get him checked. It was beautiful, and it saved my vacation because I really was not going to be in a very good shape.
Oh no.
So one of the things that was essential for that process being smooth was that I had my listings with me. And I realized when I thought of, I can say to Dr. Sugar, I can say to Dr. Jacob, hey, I have my listings. But if I said that to a patient, like, do you have your listings? A lot of times they have no idea what that is. And I thought that's a really kind of a cool topic for this podcast, because Blair listings is a very specific set of letters and numbers that is kind of like a fingerprint of your spine. And that is so important for us Blair chiropractors for the congruity of care between one chiropractor to another.
Right.
Now, if I gave my Blair listings to a doctor that doesn't do Blair, has not been trained in Blair, they're going to look at that and maybe understand some of it, but not understand all of it, which kind of stinks. I wish we had in chiropractic this like ultimate listing system that everybody understood.
Well,
and I don't see that ever happening.
We
Go ahead.
sort of do. We sort of do, because back in the day, this goes back to the pre-1920s. Back in those days, there was, listing systems involved a level vertebra that was out of a place. This was before upper cervical was the thing, and a left or right motion. But there's variances in that. And then listings really didn't come into play until Clarence Gonstead in the early 1920s developed his listing system for all levels of the spine. Most of them are identical from C2 down to L5, but they vary a little bit, and of course there's nuances there, and that is the standard listing system that is taught in all schools, except the Blair listing system isn't quite identical to that. It's a little identical, but it's different enough, and it's different from the angles, because when in the Gonstead world, when they're looking at an atlas, they are looking at an atlas relative to C2, whereas we're looking at an atlas relative to C1, which makes a difference in how you're going to approach it. So,
and he meant C0 or the occiput
right,
when you said it.
Right, right. Yes.
But yeah.
So it's understanding how the technique has developed. The approach makes it a nice shorthand for us, and we call those listings. But even amongst upper cervicals, we've got at least 2 or 3 different systems that have variations, and even variations within those systems. So it's tricky. And if you are traveling, I've got a new patient who's about 3 hours from me. She's got 2 docs. I'm the expert. And she's like, no, I've researched you. You're the man. And she's doing great with me. So she's like, we're going to stick with this for the time being. But one of the things that I'm going to have her do is take a picture of her listing card that I write up for her. And that way she has a copy of it. And
and I think that's also important that you said take a picture of it. Now I can hand somebody a card. I have like a full sheet of paper. I can hand it to them, but they lose them. Where typically you don't lose your phone, or hopefully don't. So if you take a picture up with your phone, and that's something anyone listening can ask their doctor, say, hey, can I take a picture of, how you adjust me, my listings? And first of all, they'll look at you like, oh, you know what a listing is, which is really cool. But second of all, you then have that on your phone for if you are traveling. I totally think that's a great idea.
Yeah. And that way you have it handy. I have all of mine in, I don't know how to organize, Apple kept on coming out with changes in the various softwares. I'm on an iPhone 7. My wife's on a 14 or something like that. I was trying to play with hers, and I'm like, this is dumb. It's not more intuitive. It's less intuitive, if it will. but I keep all my pictures for all my listings for all my family members, myself, Gene, my dad, couple of others, in the favorites listing.
Yeah, I put a little heart.
Yep,
I throw a little heart on
so that
there.
I can find it quickly and I don't have to mess around with it. And that way, for me, especially, if I'm like, oh, I'm visiting with dad, dad needs to be adjusted. Here's his listing. I've got that available. And I also have, in the case of my wife, Jean, she's got several because we change from time to time. And every now and then I compare, where was she last time? Where was she the time before that? Because things change a little bit, sometimes a lot. And
With certain people, for sure.
and sometimes I wonder, how far back do we need to go to reanalyze where she is now? Because she might have reverted back to something older as the healing progression has gone on. So,
How often, with a patient like Jean, how often are you reassessing with a CBCT image?
I would say we're probably 4 to 6 months, so 2 or 3 times a year. We'll review.
That seems reasonable. I have a few patients that are similar to her, and that's about what we have to do too.
And I would say, when we take a step back and look at the healing cycle that the body will go through, there is definitely a 3-month healing cycle and there's a 6-month healing cycle. So sometimes at the end of that 3-month healing cycle, you're like, something's wrong, something's off. Let's take a picture. And again, with the cone beam that we're doing now, radiation dose is so low, and we'll come back to that for discussions of terms that we use easily, and sometimes interchangeably. But yeah, the radiation dose is so low that I'm not worried about overexposures. It's quick, it's fast, and it really gives us the information we need to get a new listing. And
so actually, let's go over CBCT. And again, we won't go into the technicalities of it, but you'll hear us say that on the podcast quite often, CBCT, CBCT. And really what we're looking at is a 3D x-ray. So it's a CT scan. So cone beam computed tomography, correct?
Yes. And the cone beam is important in this phrasing.
Yeah. And
if you go into the hospital and get a CT, high radiation. I mean, it's necessary because there's
that's an emergency situation. Yeah.
Well, either it's an emergency situation, they're doing a chest CT to make sure something isn't bleeding, to have something else going on.
And that's what's great about that in the hospital is, like, if you do have a brain bleed or something going on, they can tell within minutes.
Right.
An MRI, which might give you a better soft tissue image, that it takes 45 minutes. You could be dead by then.
No X-ray, no X-ray involved with an MRI, but with this cone beam CT, and I think this is a matter of the technology. Cone beam CT is relatively new in the game, and I think it works best in a small field. So the original cone beams were maybe a little bit, the image that it would grab was a little bit bigger than a large cell phone these days. Now you can get most of the head, and now they're looking at even going one step further, using a little bit larger array to pick up everything and then to run that up and down the entire body, which will
be so cool.
It will be, and it's going to be doubly cool because right now, to get into a CT for a full body X-ray, you have to lay on your back. The cone beam would allow you to stand up in gravity, see everything, and also not nearly as claustrophobic or loud.
Oh, not at all. Yeah.
So, the only downside is it's going to take a longer scan to do everything, maybe take a couple of minutes. But, if you can stand for 5 minutes without moving a whole lot, you'll be all right. And I suspect they'll have ways to support yourself, lean up against something.
To keep you still, because it's hard to stand still.
Exactly.
But even with the CBCTs we do in our office, the chances I have to retake it, I maybe have 1 out of 50 I have to retake because of movement. Or I slightly had them in the wrong position. So we're really not retaking many of these. It's just that if somebody sneezed during it or coughed,
exactly,
it makes it fuzzy.
And the other thing to remember, the cone, sometimes we'll call it a CT, more often than not, we're going to call it a cone beam if we don't call it the whole CBCT, because the cone beam is the important part, because that technology allows for a considerably lower radiation to help us get that 3D image that we're looking for to see exactly how to create that custom correction. And that
I truly think that my patients, because I've ran the numbers, are getting less radiation dose than they did with the 7,
yeah.
8 pictures I used to have to take.
Yep. Get the same
That is incredible, and it's so it makes me, and we get like so much better pictures. The only thing that gets me is sometimes I can't get as low into the spine because of large shoulders.
Yep.
But that's okay. That's just, there's always going to be a plus and a minus, but I typically will just call them images to people talking to them now. For a while, I was still saying X-ray, 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 and I had to stop myself because I know essentially it used X-ray technology.
It's still
X-ray,
but it's not,
images.
It is not X-ray in the same fashion because of the way the technology has gotten. Because the computer itself for these digital images can figure out and do some math to put all that pieces together so we can get that 3D visualization. It is worth its weight in gold. And I think the only thing, and I haven't talked to our buddy Chris at Encompass Digital, but my suspicion is the limiting factor for where we're at right now, as far as going lower in the shoulders, would definitely be involved with the size of the array in the receiving box.
Got it.
That's my gut. I haven't looked inside that box more than maybe 30 seconds, and I didn't consider that. Now that I've worked with the machine for a couple of years, I'll have to talk to Chris about that. But in any case,
so real quick, so I can wrap this together for someone listening, is we use the CBCT images to come up with a listing on a person.
Correct.
That listing is unique to that person and tells a Blair chiropractor, or any chiropractor, but if you do Blair, and we did a Blair analysis on that CBCT, it tells any Blair chiropractor the angles and the adjustments that need to be or could need to be done on that person.
Exactly.
Now, just because I see a misalignment
and
or
that's
a
what I was
shift
going to say
on a picture, does that mean as a chiropractor I should adjust every misalignment I see?
Absolutely not, because that is, you beat me to it, because I was just going to say that what we see on the X-ray is what we call a misalignment. That misalignment is, we've created definitions that take the misalignment into a listing. But then we have to connect that to what is neurologically going on in the body that needs to be addressed. And there's a couple different names for that. In our offices, we call it a shift. I call it a neurostructural shift. You call it a global shift. In chiropractic, you've probably heard the term, if you've been to a chiropractor before, subluxation.
And if we break down that word real quick, just so somebody listening can start remembering what, if they hear other people saying it, sub means less, lux means light. So the term came from a decrease of like the energy, less light. And I think that's a very, for something that they came up with 100 plus years ago. It's a beautiful term for what we find. But what we have found, that there's terms now that we can use that explain it to modern people better.
I would concur, because the subluxation is one of those weird words. I still like the word.
I don't hate it. No.
Right. But I find that it gets into this weird space where when people start seeing medical terminology, and medical terminology oftentimes rules the day, especially on an X-ray. There are two different versions. So there's something called a luxation, not a subluxation, just a simple luxation in medical imaging that actually shows a joint surface that is beyond its normal limit. I mean, significantly beyond. And that may require, or typically require, surgical intervention. In the medical terms, there is a term called subluxation that is something just less than that. What
Mhm.
we are dealing with in chiropractic is not necessarily even to that severity. So we have we have the same word with two different definitions, depending upon whether or not you're in medical terminology or a chiropractic terminology.
Yeah. And I think that is an issue that can be an issue between a medical doctor and a chiropractor. Because if I was to come up to a medical doctor and says, your mom has a subluxation, they'd be like, let's get her to the hospital.
Yep.
Oh, Lord.
Well, and
Does
it
she need
also has a
surgery today, or
problem.
when do we do surgery?
It also has a
Possibly.
problem because both, all three definitions, subluxation chiro, subluxation medical, and luxation, all three of those are way too complicated for the average individual. I want to make
Agreed.
it simple for everyone to understand, which is why shift comes into play. And for especially when I'm looking at this stuff, we've got significant brainstem involvement, not necessarily bone on the nerve, but because of the dentate ligaments, they're pulling on that, and it's deforming the spinal cord and or brainstem and or the vertebral artery going up into the brainstem, which can reduce certainly blood flow on one side and sometimes cause a physical shift of the what is that artery called? It's the one where the two vertebral arteries come together. And it's not coming to me. It'll come to me.
Circle of Willis.
Well, that's part of it.
I know. I'm just trying to think of what it is.
There is one that's central to the caudal portion of the.
Well, all of our listeners right now are just dying to know what it is.
They are, but we have seen on MRI was when people are laying there that central artery where the two vertebral arteries come together can be shifted to the left and then all of a sudden go to the right, which implies to me that you've got a strong artery that is not sitting where it's supposed to be, generally center to the brainstem. That means it's moving around and potentially causing pressure where it was not designed to have pressure. So, any case, that's neither here nor there. So that's where I start looking at these things from a neurological perspective and saying, "Oh, we have this problem, we have that problem, and all of these parts and pieces come together." So, again,
basilar artery.
Thank you. I can't.
I had to look it up.
Thank you.
But once I saw it, I was like, duh.
I know, right?
So, but there's a third portion too. So we talked about neurologically, it's changing how the brainstem sits.
Yeah.
We have circulatory, and then we also have cerebral spinal fluid dynamics changes.
Yep.
So none of which we can see on the CBCT.
And we don't see it well on a typical MRI either. Yeah. We have ideas, but we don't get a good sensation of how it's pulsing or not pulsing, how fluids are not flowing until you start getting into what they call cine studies. And cine just means cinema, but it is a movement study of a single slice of the MRI to see what's moving and what's flowing and what's not flowing. So
when we hear, which we hear unfortunately very often, is why didn't my other doctors tell me about this?
Yes.
That's why we have this podcast.
Right.
Is because they, first of all, just don't know what they don't know. Just like I don't know what I don't know, and you don't know what you don't know.
Yes.
And
actually, I've got a pretty good idea of what I don't know. It scares
you do not know what you don't know.
Yeah. I mean, it scares me what I don't know because I've got just enough inkling. I'm like, oh, okay.
But then you don't know. See, the thing is, so there's a tiny portion of you don't know.
I don't know how deep it goes, but it scares me.
Yeah, but that's the issue where there's a frustration that people will go through when they listen to us talk about this in the office or here on the podcast, and your brain kind of does this little poof moment of, this makes so much sense.
Mm-hmm.
I really why don't I know more about this? And why has nobody told me about this before?
Right. And again, why we're doing this. Why we're here on Sunday afternoon and I'm not playing my bass and you're not out walking Sammy.
She would love that. It's so pretty out.
Yes, it is.
So this leads us to this word. Now we have this subluxation or global shift or structural shift or neurostructural shift. So what we have is two parts. We have a misalignment we could document on CBCT, And we have neurological tests, and let's not go over those today. Testing that we did in the office to figure out that this particular misalignment that we saw on the image is active. It's causing problems for this person. So now we have to do something about it. And there are many different words chiropractors use for what they do. So the physical thing that they do.
Yes.
I still typically call it an adjustment.
Sure. And I would concur. Sometimes I like to use the word correction interchangeably there. In chiropractic history, that means two different things, but I like that because we are correcting the problem that is an underlying issue. I don't like using the word manipulation.
Why? Is because if I was to manipulate you, that sounds bad.
Exactly.
Like, my husband is manipulative, like he's not. But like if somebody said that out loud, you'd be like, ooh, that sounds awful. What'd you say?
If anyone in your family is manipulative, it's you. Because you're
not wrong. I know what I want and I get it.
Yes.
So that is, adjustment, correction. Any other words you can think of that people use?
Those are the big ones. I can't think of anything else that comes into play. But those are the big ones that along those lines, and that's what we do. And then we have, it needs a better word, but the best thing we have is our resting areas. It's restoration is really what we're doing. But unfortunately, we call it a rest area, and most people associate
a rest room.
or a restroom, both of which people associate with rest stops on the highway.
Or going to the bathroom in general.
Exactly. And quite honestly, ours do not smell as bad as some of the ones that I stopped at because I was over in Indianapolis this weekend. We
could call it a relaxation suite.
We could, but the goal is really restoration, because at that point in time, why do we have people rest? It's because why do they need that 20 minutes? Because you need at least that long, 15 to 20, to let your body get used to the new position and settle in and relax. I find that if you don't take the breaks when you're supposed to, if you don't take that breath, you end up actually rushing back into the same policy that got you in trouble in the first place. You run back out into the environment outside that is designed to make you go a little crazy and ramp up your sympathetic nervous system. I know the roads that you're on for your office, and there is one road that I will drive. If I have to go to your house, there's one way I exit. And if I'm headed to the highway, there's a different way that I exit because it's just more convenient. And if I want to go to the barbecue place, I'm going to take the long road, or at least I should.
It is very good. So that time that people take after the adjustment is weird.
Yes.
In general. I mean, most people end up loving it. But for if we look at all chiropractors,
right,
and put them all out there, a very small portion of chiropractors have people rest after their adjustment.
Yep.
And first of all, because it takes time for us, like we have people in the office longer. Yep. So patients will be anywhere from 20 to 30 minutes in my office.
Yep.
But I agree. It's so important. When I have a patient's like, I don't have time to rest, doc, and I'll be like, well, see you next week.
You will be back sooner than you want. So
and it's not maybe always true, but it can be true, and they know it.
True, but it is more true, because I remember, and this is the other problem why a lot of docs won't have a resting area, is because they don't want to have that extra office space and pay the extra rent, because they're not, because the space isn't utilized and monetized in a good way. The problem is Dr. Tom Forrest had a coach. I had the same coach later, and the coach changed his mind after he sort of found himself in that same boat. But Dr. Forrest had a coach that basically said, get rid of that resting area. It's not making you any money, and you don't need it. And within about 2 or 3 weeks of not having the resting area, his patients started complaining because they weren't holding their adjustments as well. So it really does make a difference. And overall, when I look at the profession, when I hear about other people coming in from other docs and how many visits they wanted 3 times a week for 18, 20 weeks. And I'm just like, no, we don't need that.
That's a lot.
We might need twice a week for 4 to 6 weeks, but
Yep.
because of the rest, we can definitely, keep it to that lesser amount. And oftentimes, it's not uncommon for me to, plan for 6 weeks of twice a week, and then all of a sudden see it, at the end of 4, we're like, no, we're good.
Yep.
And then reduce them to
Yeah,
one.
I always try to plan for the worst with patients, and then it's a way easier for us to be like, oh, let's just decrease it. You're doing great, versus saying, yeah, it was wrong. You need to keep coming in longer.
Well, and unfortunately, I would say, my general game plan for patients is that middle of the road where we can go backwards. It's the cases that are in really tough shape, and I can't tell the cases that are really tough shape from the cases that are bad, complex cases, but they get well fast.
Yep.
And there is no magic crystal ball at that point in time.
Truly
But
not.
usually after uh, about 6 weeks, where I'm like, okay, this is not going as well as we had planned.
Yeah.
So, sometimes you have to anticipate that to get people back to where they're supposed to be, and sometimes you just can't.
Yeah.
But in any case, that's restoration for you.
Yeah. And I like that. I think I'm going to steal that from you and start calling it restoration room, because um, it makes a lot of sense to me.
Yep.
And that it's about, not that I do call it restroom, but if I did,
Nap time.
but that's what I have to make sure I don't say, and I don't shorten it to restroom. So maybe I'll call it
Yes.
restoration suite.
Yes.
So I don't call it a
Ooh, I like
restroom.
that. I like that. That's even better. And the funny thing is, as an aside, I tell people as I'm laying them down for the first time, it's like, all right, we're going to have you rest here for about 20 to 30 minutes, usually 30 on the first time. Snoring is optional. I've rephrased that to remind them, not only is snoring optional for them, it might be optional for somebody else. So it's a little bit of you're open to do it, but it's a warning somebody else might as well. So
Yeah, there's other people in the room with you.
exactly.
Yeah, I had a new patient come in, and then her mom started care a week later, and they were in there chatting away with each other.
Yep.
And I was busy going back and forth, and one of somebody else said, "Oh, they're really talking in there." I was like, "Oh," and it was just about time for them to come out. And I had to say, "Hey, next time it's really about restoration, not about talking. You guys have plenty of time to talk afterwards." So,
Yeah.
but they were just having a great old time chatting about stuff in front of other people.
It is.
Uh,
It is one of those things where you get a family in there, and all of a sudden they're catching up. Especially, I had a similar situation not too long ago where the daughter is in college and she's on the go, but she's in college locally, and mom's not seeing her as much, so they're catching up because they haven't been able to have a dinner together. So,
yeah.
any case, what else we got? Do we have any other terms that?
Let's see. Anything else that's chiropractor would, if you guys are in the comments tonight, when you're, or
Yes.
whenever you are listening to this, write down, hey, what about this? What about that?
Yep. We'll come up and revisit.
One of the other things that I can think of is holding.
Yes.
And because when people you say, "Oh, I'm holding," if you are a drug dealer, that's a bad thing, or it's a good thing if you're a drug dealer. You're holding, meaning you have drugs. So
It
I was told that.
depends, you know?
I never really thought about that until one of my patients mentioned it to me. Hey, when I hear this, and I was like, "Well, tell me about your past." So that is one of those words. Also, holding your correction,
Yep.
that a lot of people might not know what it means. And it just means you don't need to be adjusted, which is really cool. How do you explain that to a patient?
I tell them that my job is not to adjust them every time they come into in for a visit, my focus is really on making sure we get this bone back in place so that it can stay there for as long as possible. The longer it stays in place, the better the body's ability to heal and correct its other underlying conditions goes. Because we're not a headache doctor. We are a neurostructural chiropractor. And what that means is we're focusing on the segment that is out of segment or segments that are out of place that are preventing your body from functioning and healing the way it's supposed to. And the sooner we can get you holding, the better off you're going to be right off the board. So we get them healing, and all of a sudden, if I had needed to adjust you, if everything is right and I need to fix it again, if I fix it again, it's going to get worse, which is why we are also very sensitive to not adjusting when we don't need to, because that can actually make things worse if we over adjust.
Yeah. So one of the ways when somebody asks me about that is I explain it. If I have a hammer or a nail in the wall,
right,
and it's sticking out and I want to put it all the way back in. So I take my hammer and I hammer, and now it's in the wall.
Yep.
And a week later, that thing's popped back out. Well, I'm going to go grab my hammer and hammer it again. And so a week later, I come by and it's all the way in the wall. I'm not going to go grab my hammer and hammer it further into the wall.
Yes.
And put a dent in the wall, because now I've caused injury to the wall. So that's the very simple way I explain when someone's not understanding holding an adjustment is we don't need to put it in extra. And people will say that to me too, is like, I'm going out of town. Can you just give me one to have me last through the week?
Exactly. Or they're experiencing some of the symptoms that they were experiencing beforehand. They're not as bad, but they're like, Doc, something's off. And I'm like, and we check them, and all of a sudden it's like, no, you're fine. You might have some other, healing going on, but you're not out of adjustment, because the less we have to adjust, the better. Unless people want to come in 3 times a week for, the rest of their life. I mean, it's good for our pocketbook, but, not necessarily getting them better.
No. And I do find that very occasionally, if I haven't explained that correctly to someone, someone will get mad when they don't get an adjustment, when they don't feel good. And I understand, because when I don't feel like, if I would have went to Dr. Jacob with all of these symptoms and not been out of alignment, I wouldn't have blamed him. I know better than that, but I would have been like, oh, because I know an adjustment would have helped me feel better.
Right.
But I had to have been the right adjustment. If it was the right adjustment, the right time, I had to have been out, and he was able to detect that and tell me for sure that's happening right now and you need an adjustment. And he did an excellent job. Oh, props to him.
Nice job.
And yes. And honestly, I wouldn't have hesitate. I've referred a few patients to him, not knowing him other than talking to him on the phone, but I would not hesitate to send everyone to him that is in that area. Amazing doc.
Good to know too.
But not on the Blair website.
Well, folks,
I talked to him about that. He thinks in his mind that he has to be like certified to be on it. And I was like, no, as long as you're doing Blair chiropractic to 80% of your patients, you can be on the website.
And folks, as an aside, we are upgrading the Blair website in general. So if you're looking for a doctor in your area, or just curious, and reach out to us if the Blair website isn't working.
Yes, you can.
It's going to be back and forth.
Yeah, and we've been we're really between us two, we know a lot of the upper cervical chiropractors
maybe
in the
most.
world.
Yeah, maybe most, which is pretty scary.
It is scary. I think we need more. That's why I was excited to meet Dr. Jacob, because he is a fledgling chiropractor. He's probably 5 years out. I know that seems like, but that's still a pretty young chiropractor. And a really nice guy.
Well, good.
Okay. So holding, we went over subluxation, we went over adjustment, we went over holding, we went over CBCT. I
think those
listing.
Oh, coming back to listing. Yeah.
Yeah. So those are some terms that we've used on the podcast before, and we explain them a little bit. I think it's nice to explain them more, and it's a good point to educate yourself on what those mean so that when your chiropractor or someone else says those words to you, you know, like, hey, I know what that is.
Yep.
Good deal.
That's about all I've got today. It's sort of one of those afternoons.
Yeah. No, I'm done. My brain's done for the day.
Yeah, I've got some basin to do and dinner and call it a night. So
Yeah, and we got a busy Monday starting off bright and early.
we do. And I know I've got a student coming in to shadow me tomorrow from coming down from Palmer. So we're excited to have.
Oh, that's fabulous.
Yeah, so that'll be nice. But in any case, I think that's about it.
Okay. Well, where can they find you, Dr. Sugar?
I am at KeystoneChiroSPI.com, Keystone Chiropractic in Springfield, Illinois.
And I'm Dr. Beth Bagley. I am in St. Louis, Missouri. We're on the west side. You can find us at precisionchirostl.com on all the socials.
Make sure you like, subscribe, give us a 5-star review. If you got questions that you want answered, go ahead and either website of ours are good places to send an email and make a question request or a topic request. And we'd be more than happy to share. So
absolutely love it.
Until then, we'll be back next week with another episode of The Blonde and the Bald. You guys have a great one.
Bye.
That's all for today's episode of The Blonde and the Bald. Don't forget to like, share, and subscribe. If you enjoyed today's show with Drs. Bagley and Sugar, remember, don't give up and just live with the pain. Come back next week and get more answers and solutions. Visit our websites at KeystoneChiroSPI.com and PrecisionChiropracticSTL.com for more info and catch all the episodes of The Blonde and the Bald.